Tony?
Is Tony available?
Tony, we can't hear you. There's all kinds of feedback. Do you want to try again? Okay. Come back to Tony. And then, let's see, there's someone else.
T. Johnston.
T. Johnston. Would you like to unmute and go ahead and introduce yourself?
You're unmuted.
Go ahead. Okay.
If you can't unmute or talk for any reason, you can just type who you are and who you're with in the chat box. Lucia will capture you there. Thank you.
Oh, I see. Tony's having some trouble hearing us, but I hope it works out.
Oh, and that's us to him.
Oh, okay. All right. So I am going to turn things over to Jessie, and she'll lead us through. And then we're excited to have Fallon as a person who will provide a case study for us to discuss.
Yes, great. Great. So Lucia's putting up a PowerPoint, and we'll talk today about co-occurring anxiety and substance use disorders. Again, if you work in a 245G program, this meets your requirements for some co-occurring treatment training, which is great. You need 8 to 12 hours of that every year. So let's get started. So today we're going to talk about specifically how anxiety and the different anxiety disorders, which I'll talk about in a little bit, what kind of disorders are under that umbrella of anxiety disorders, but why those so frequently co-occur with substance use disorders, and how we can offer some treatment that addresses both things. So to get started, first thing is, what is anxiety, or what do we mean when we talk about anxiety? Again, we're going to talk about how you get diagnosed with an anxiety disorder, which is in this great, big diagnostic and statistical manual of disorders, of mental health disorders, or the DSM. That's what we use to diagnose mental health conditions. And what is common to all the anxiety diagnoses that are in the DSM is that they all share features of excessive fear and anxiety and some related behavioral disturbances. And they say the definition that they use of fear is the emotional response to a real or perceived or imminent threat. So perceiving that you're in danger or really being in danger. But the fear response is that emotional response that you might have in that situation. And then anxiety is different because it's the anticipation of a future threat. So it may not be an actual or real or perceived threat in the moment, but fear about a future event happening to you, which is normal. A lot of us feel anxiety, and we'll talk about what makes anxiety a diagnosable condition rather than just normal feelings of anticipation of potential threats, because that's an adaptive response we all have. Just a little bit about how prevalent this is, that anxiety and substance use disorders co-occur. For one thing, anxiety disorders and substance use disorders are among the most prevalent mental health conditions that people can have. Anxiety disorders are about 31% of the US population is going to have one of those diagnoses throughout their lifetime. So almost a third of all of us in the US will have an anxiety diagnosis at some point. And substance use disorders are not far behind. I think it's about 26%. It'll be later in the presentation, over the course of a lifetime, that somebody might be diagnosed with a substance use disorder. So they're both really prevalent in the population. And so the co-occurrence is really related as well. We'll talk about why that is a little bit later on, and when we talk about some of the brain reasons behind anxiety. But when anxiety disorders and substance use disorders co-occur or happen at the same time, it's associated with greater symptom severity, meaning both symptoms of both disorders are more severe than if they were happening by themselves. Greater functional impairments, meaning greater impairment in different areas of life like work, school, functioning, our daily functioning, and poorer course of the illness together than alone. So if you have both diagnoses, you're likely to have a poorer course of the illness, or they may get worse instead of getting better, more likely than if you had one or the other. So among people who have an anxiety disorder diagnosis. AD there is anxiety disorders. Of those people with anxiety disorders, almost 15% have had a substance use disorder in the past year. And then among people with substance use disorders, almost 18% had a past year anxiety disorder diagnosis. And for the population that seeks treatment, it's higher. It's 33 to 43% that will also have an anxiety disorder diagnosis. Among those drugs of abuse that we see in treatment, there's a particularly high prevalence of anxiety disorders with opioids, sedatives, and tranquilizer dependence. Lifetime comorbidity of those drugs with anxiety disorders is around 60%, which is really high. And I think we'll see when we talk about the brain changes that happen in anxiety, that those drugs are all have sedative or depressant effects, meaning they calm the central nervous system, where anxiety is a heightened response. So it's sort of a way to numb that anxiety response by using drugs like those that are sedatives. Let's see here. Okay, we're going into the brain again. I always love to show this because anytime we're talking about emotional disturbances like anxiety, depression, last echo session we talked about PTSD. We're talking about the stuff that's deep in the brain, those parts of the brain that are inside, kind of the instinctive or reptilian or limbic part of the brain. So on the left there you see the outside of the brain. Those are the lobes that we often hear about where our thinking occurs and processing. And we're talking about the second, that part of the brain that's on the right side there, everything that's inside. And I'll go to this a little bit more complex picture of the brain. And I know it's going to be hard for you to see on the slides, but I'll talk through a little bit about what happens in the brain with anxiety. So normally what happens when we have some sort of stimulus, we have sort of a regular way of making sense out of what's happening. So what you see marked there as B, or the high road, that's what's supposed to happen. Our thalamus, which is that kind of blue-green thing in the middle, takes in information from the outside world. It processes that sensory information, and then it signals other parts of the cortex, or the outside part of the brain, the thinking part, to make sense out of what's happening and then respond in some way. So that's what's supposed to happen, is there's some sort of sensation happens, a sound happens, or we see something and we think about what does that mean, make sense out of it, and react. What happens often in anxiety is that there's sort of a shortcut, that A that's marked with an A there, where the amygdala, which is really our emotion center of the brain and the fear, fight, or flight response kind of part of the brain. That's that red little bean-shaped thing underneath the thalamus there. If that gets triggered, it triggers the fear response right away. So it short circuits. It doesn't even go through the cortex or the thinking part of the brain. It just triggers an emotional response, which is fear, and responds out of that. So it's and what's interesting is that smells and touch sensations are much more likely to go to the amygdala and produce that emotional response than things like sights or sounds. So sights or sound usually go through that thalamus, a thoughtful response. We can kind of figure out what's happening, but smells and touch are much more likely to trigger a fear response. So that's where smells are often produce really vivid memories for us, and because they're tied to that emotional memory, and also the same with sort of physical sensations that we have. So those things, if we smell something or are touched by something, that is more likely to produce a fear response or an anxiety response rather than a thoughtful or more rational response. So some other pieces of the brain that are important in anxiety, there's that tiny little blue strip underneath the blue-green thalamus. That is the bed nucleus of the stria terminalis. And what's important about that in anxiety is that starts to perpetuate the fear response. So it anticipates more fear coming, and it's more likely to kick in for things that maybe aren't necessarily fearful or fear-inducing stimulus. But if that bed nucleus, that little blue strip, starts to fire with the amygdala, it's going to embed that anxious response and anticipate more fear. So it really embeds that long-term anxiety or unease where we're walking around with a little bit heightened fear response in all situations, and we start to have an anxious response even when one's not warranted. And then there's a little orange kind of piece there lower than those thalamus and amygdala organs there. That's the locus ceruleus, and that initiates anxiety symptoms by activating that central nervous system. So when the amygdala, that red part, fires and does that fight or flight response, that signal goes to the locus ceruleus and says, something's happening, we need to respond, activate, get activated, start to panic, start to have some symptoms that are related to fear, anxiety. And it's the piece that says, there's something here to panic about. And so let's get reactive. And then the hippocampus, which we've talked about last time in terms of PTSD, that's our memory system. That's that green, longer strip of brain there. That's the hippocampus. That stores memories that are tied with an emotional response. So that's in anxiety, which starts to say, oh, I remember last time I saw something like that, I was afraid, or something scary happened, so I need to be afraid of that thing. So that's also important in anxiety, because it starts to perpetuate this idea that I need to continue to be scared of things, even when maybe I don't. Maybe that was a really specific circumstance that happened, but the hippocampus sort of stores that as a scary thing or a scary memory. So I think that's interesting to hear about kind of what happens in the brain, because it helps us to treat some of those symptoms that we're having when we have anxiety. So here are the kind of the classic symptoms of an anxiety disorder. They're all going to have excessive anxiety and worry, or apprehensive expectation of something happening. And the key word there is excessive, because like I said, anxiety is pretty normal. All of us have it. But if it's excessive, meaning more than you really need to have in a given circumstance, or more than is normal, that becomes a problem. If you're having a bigger response to something than it really needs to have. The second symptom is difficulty controlling that worry, not being able to calm yourself down when you're having those anxious feelings. And then the third one is that the worry and the physical symptoms that are associated with that cause significant distress or impair your functioning. So not just that you're feeling anxious, but that anxiety gets in the way of your daily living in some ways. Either you're afraid to go somewhere, you can't go to your job because you'll have to talk to people. You might have specific fears that we'll talk about that get in your way of just doing what you need to do during the day. And then the fourth major symptom is that you have some sort of change in behavior due to that worry. You might avoid certain circumstances or people. You might use substances to numb those feelings of anxiety, or try to calm yourself down in maybe unhealthy ways. So something about the way that you act changes because of the anxiety. So let's see. I wanted to point out that anxiety symptoms look a little bit different in kids. And I think that that's important to notice, because kids aren't necessarily going to be able to tell you, like, my anxiety seems excessive and I'm not able to control it. What you're going to see from kids often is going to be physical symptoms. They're going to talk about stomach aches, headaches, nausea. They might even have vomiting that's unexplained by physical maladies or anything like that. You're often going to see nightmares or sleep disturbances, kids who can't sleep through the night or have really scary thoughts or dreams. Often kids who have anxiety have difficulty with transitions, going from one thing to another, and need a lot of kind of coaching and help around, now it's time to go to school, or now it's time to stop doing what you're doing and go to somewhere else. Just that change in their routine is scary for them. It causes some anxiety. With kids with anxiety, you're also going to see a lot of clinging, and we'll talk about separation anxiety as one of the diagnoses that can happen around anxiety. So kids who don't want to leave an adult or a caregiver or a friend, or they have really clinging behaviors and don't want to be left alone, those kinds of things are really significant indicators of anxiety. They might limit their activities, not want to do certain things, not want to play certain games, play with certain kids. Maybe more so than they used to, or more than other children, just because there may be some anxiety there. You often might notice loss of appetite or eating issues in kids. That might be an indicator that there's some anxiety. Either they have stomach aches and they don't feel like they can eat, or they're really scared about something that they might not want to eat at all. So these are all just kind of signals to think about and ask maybe about worries or anxiety in kids. Crying, excessive tantrums, or tantrums that aren't really explained. All kids have tantrums. But if it's sort of not clear what the trigger is, it might be that something is making them anxious and they don't know quite how to communicate that. So And then the other one would be freezing up, shrinking, kind of failing to speak in certain circumstances. There is a diagnosis that we'll talk about around failure to speak, selective mutism, but any of this kind of worry or anxiety in social situations in kids is maybe going to look more like that than what we would see as, I feel anxious when I have to speak to someone. The other important thing to note is that anxiety can look different across cultures, and there's a lot of cultural differences in what might constitute an anxiety disorder. So we have to pay attention to how we interpret those symptoms or how we look for symptoms in somebody who's maybe not of the majority culture. So one thing is that the expectation around when kids separate from their caregivers or the age at which they're supposed to separate from caregivers might be different across cultures. So when in our culture, it's like in the teenage years, there shouldn't be a lot of anxiety about separating from a caregiver or parent. In another culture, that might be too young. That might be not the expectation that that kids are able to separate easily from caregivers. So just thinking about how to make sense of what might look like to us anxiety might just be a cultural difference or might be a cultural expectation that we're seeing. Also, if somebody's got language differences or their primary language is other than English, that might we might see that as anxiety, or when it's actually just inability to communicate in the way that they want to communicate, or that also might exacerbate anxiety. So somebody who doesn't speak the prevalent language might experience a lot of anxiety trying to communicate and not be able to. There is a lot of information in the DSM about diagnoses that might be prevalent in other cultures other than the US culture. For instance, there is a diagnosis in Asian cultures around fear about making other people uncomfortable, which is not a diagnosis that we have or use here in America, but that there's a lot of fear about how I make someone else feel, and that can be anxiety producing for people, especially in other cultures. A lot of other cultures have very different words or ideas about what anxiety is, so they might not respond at all to that word anxiety, but worry or nervous or some of these the physical symptoms that might be what they identify with. So be careful when using that word anxiety, because it might not resonate for somebody from a different culture, and you might have to find out what the word in their culture is or what the more acceptable terminology is in their culture. And again, for maybe that same reason, a lot of other cultures will focus on those physical symptoms that, my stomach hurts or I get nervous stomach, or those kinds of phrases that might be the part that they feel like they can talk about, and not so much about the emotional anxiety. So paying attention when somebody's having physical complaints around that might be links to anxiety. And so I think just in general, we have to consider with the cultural context if we're deciding whether or not worries are excessive. There's a lot of belief systems in other cultures that might mean that things that we see as excessive worry aren't really. It makes sense in their culture. So we want to make sure that we're not kind of making more of something than it needs to be in their cultural context. So here are the different anxiety disorder diagnoses that are in the DSM. There are lots of them, and they're kind of arranged in order of developmentally when you might see these emerge. So the two specifically that emerge often in childhood are the first two: separation anxiety disorder and selective mutism. Often those are things that are diagnosed in childhood and may or may not move into adulthood. So separation anxiety disorder is really severe and anxiety about separating from a caregiver, so severe that it impairs the child's functioning in some way. Maybe they're not able to go to school, not able to get on or off the bus because of that fear of separating from their caregivers. So it's fear and anxiety concerning separation from an attachment figure, lasting at least 4 weeks in kids and 6 months or more in adults. So it does get diagnosed in adults, but the time frame is longer, and the symptoms that you're looking for are probably a little different. But just so you get a sense of the prevalence of these different diagnoses, only about 1% of adults are diagnosed with separation anxiety disorder, but about 4% of kids are diagnosed with that at some point in their childhood. So it is fairly common. And again, this is different than a phase of separation anxiety that most kids go through where they're pretty attached to parents. This would be more severe and have some of these kind of key anxiety symptoms that go along with them. Selective mutism also generally diagnosed in children, but only less than 1% of children are diagnosed with selective mutism. It's diagnosed as a failure to speak in public, so it's not necessarily an inability to speak or that there's a physical reason for not being able to speak. It's that the child fails to speak in certain situations, and the cause being anxiety. It has to last at least 1 month to be diagnosed as an anxiety disorder. The rest of these are kind of commonly seen in both adulthood and at times in children. I'll talk a little bit about some of the prevalences. Specific phobias are what you think of as specific fears about specific situations or things. The ones that are most common are things like, let's see, I think they categorize them. Animals is a common one, certain animals. The natural environment, things like fear of heights, storms, or water. There's a category of blood injection or injury phobias, so things around seeing blood, having injections, or potentially illnesses or medical treatments. Those can be specific phobias. Situational phobias would be things like airplanes, elevators, enclosed spaces. So those kinds of really specific situations that people might avoid or create a lot of anxiety for somebody. And then there are others that are mentioned in the DSM, specifically fear of choking or vomiting is something that a lot of people have. Fear of loud noises, and for children, often fear of costumed characters can be something that comes up that produces a lot of excessive anxiety. Again, it's got to be excessive, more than that situation really warrants, and unable to control the anxiety. And for specific phobias, about 5% of kids are diagnosed with that as an anxiety disorder. 16% of teenagers, it's very common in teenage years to have a specific phobia like that, and only about 4% of adults. So that's a very common and maybe developmental stage that a lot of people go through. Social anxiety disorder used to be called social phobia and was one of those specific phobias, but now is its own disorder, diagnosed separately, and that's the fear of being in social situations or speaking in social situations that's more severe enough that it gets in the way of people's functioning. So that's maybe somebody who really feels like they can't answer the phone or answer the door and doesn't leave their house because they're worried about talking to people or running into people, maybe can't hold a job because they can't interact with people on a regular basis and have some panic and fear about that. That's about 7% of people in the US are diagnosed with social anxiety disorder. It's a pretty common diagnosis that we see. Panic disorders is the presence of panic attacks on a regular basis. About 3% of people are diagnosed with a panic disorder, and the key feature of that is a panic attack, although you can have panic attacks with lots of different diagnoses, both anxiety disorders, but also other kinds of mental health issues. So you can have bipolar disorder with panic attacks. You can have depression with panic attacks. It can be a specifier, meaning it's one characteristic of a lot of different mental health diagnoses that people can have. So just having panic attacks as your key symptom would mean that you have a panic disorder, but you can have panic attacks as part of any other mental health condition as well. And I'll talk on the next slide about what the characteristics of a panic attack are, or how you'd be diagnosed with that. Panic attacks, actually, 11% of adults have been diagnosed with a condition that has panic attacks as one of the symptoms. Agoraphobia, again, is a type of specific phobia. It's really about fear of going out in public or going out in open spaces. It's less than 1% of adults, so it's one of the more, it's a less common specific phobia. But again, one that we hear a lot about because it requires some treatment there. And then generalized anxiety disorder is one that you'll probably see most often. It's, I guess, only 1% of teens and 3% of adults, but females are twice as likely to be diagnosed with generalized anxiety disorder, or GAD. Generalized anxiety disorder is really that feeling of anxiety that's excessive and not able to be controlled, but that's not specifically linked to any specific trigger. So it's generalized. It happens all the time, regardless of whether you're in a scary situation or in a certain type of situation. It's somebody who feels a lot of anxiety all the time. So that's a fairly common diagnosis that we see in substance use disorders. And then there's another category of anxiety disorders that are substance-induced or medication-induced, meaning that that the person feels anxiety because of a substance that they're taking or a medication that they're taking. And so that's often something that we might see with substance use disorders, is that a substance that they're taking, perhaps a stimulant like methamphetamine or cocaine, is causing anxiety for the person, so that they don't feel that anxiety when they're not taking the substance, which is an important distinction. That somebody doesn't have an anxiety disorder and then uses substances to cope, but creates anxiety by using the substance. And similarly with some of the medications that might be prescribed, if they're stimulant medications, they might stimulate an anxiety response. So you look for that as far as a side effect of medications that people might be taking, but also as a way to determine whether or not an anxiety disorder came first and the substance use second, or vice versa. Let's see. Oh, so I promised this, the panic attack symptoms. To be to be diagnosed with having panic attacks, again, whether that's a panic disorder or if it's a symptom of another type of mental health issue, you'd have to have 4 or more of the following. One key factor is palpitations, pounding heart, accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling like you can't breathe, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, or faint, chills or heat sensations, paresthesias, practice saying that, paresthesias, numbing or tingling sensations, derealization, feeling like you're not in reality, or depersonalization, feeling detached from yourself, like you're watching yourself from above, is a common thing that people say about that depersonalization feeling during a panic attack. The fear of losing control or fear that you're going crazy, and the fear of dying. Those are often symptoms that we hear about with people who have panic attacks. And you can see from that list why someone who has a panic attack often feels like they're having a heart attack. And so that's something that we often hear from our colleagues in emergency departments, that often people show up in the emergency department thinking that they're having a heart attack or something similar, and it's really a panic attack. So that's not actually a heart condition that's leading to these symptoms. It's anxiety that's leading to these symptoms. So it feels to the person who's having it like it's a real medical condition often. All right, what's coming up here? So as far as anxiety and substance use disorder clients together, and why these things happen together so often, one thing to note is that the diagnosis of an anxiety disorder in the context of a substance use disorder is complicated by the anxiolytic and the anxiogenic effects. Anxiolytic is the anxiety reducing, and anxiogenic is the anxiety producing. So and those are the effects of many substances of abuse. So a lot of substances of abuse reduce anxiety and some increase anxiety. And so that complicates how you diagnose an anxiety disorder or not in the context of having a substance use disorder. So anxiety might be masked by substance use, or it could be exacerbated by the effects of substance use, especially in the intoxication, withdrawal, or in chronic administration. So someone who's using often and frequently. Some studies have found that there's more support for the idea that anxiety disorders come first and substance use comes second. So when you can control for things like that, it's more likely that people are using substances as a way to cope with anxiety rather than having a substance use disorder first and developing anxiety later. So it's more likely that substance use, that kind of coping strategy or self-medication theory is at play with anxiety disorders, that people feel anxious and they use substances to reduce the anxiety. Last time we met, we talked about the interplay between PTSD and substance use disorder, and that self-medication is one theory out there about that people use substances to cope with PTSD. But there are also some theories that said maybe being in a substance use lifestyle creates more likelihood. Either you're at higher risk for trauma or traumatic situations, or you're more susceptible to develop PTSD after you have a traumatic situation. And I should mention here, PTSD used to be considered an anxiety disorder. In the last version of this DSM, it was included in that list of the anxiety disorders because a key feature of PTSD is anxiety, certainly a re-experiencing of the trauma that happened. But they since, in this version of the DSM, pulled all trauma-related or trauma-triggered anxiety disorders into their own category. So that now there's a trauma-related or stressor-related anxiety disorders, and PTSD is in its own category with those. So separating out when there's an actual traumatic incident that leads to anxiety versus there's anxiety regardless of the situation. Let's see. So co-occurring rates, I talked a little bit about this before, that 31% of US adults or US people in the US will have a lifetime diagnosis of anxiety disorder, have a diagnosis of that sometime in their life. 26.6% is the likelihood that someone will have a substance use disorder sometime in their life. So both really high lifetime prevalences, and they co-occur very often for those reasons that we just talked about. Self-medication often is reducing that anxious response. And like it said on an earlier slide, people with anxiety disorders are more likely to abuse opioids and sedatives and things like that are going to reduce, and alcohol is the other one that wasn't specifically listed, but as ways of reducing anxiety. I put here this graph, which I think is really helpful to remind ourselves of. It's the amount of people who are diagnosed with a substance use disorder or mental health issue who don't get any treatment. And it's pretty shocking. I mean, it's a lot. So for substance use disorders, that first bar there, 92% don't get treatment for that. So 26% of us will have a substance use disorder in our lifetime, but 92% will not get any treatment for it. Hopefully we'll change that statistic in our lifetime. But similarly, not quite as severe, but for mental health issues or any mental illness, that second bar, a lot more people are being diagnosed with mental illnesses because there are a lot of them, this whole book full, but almost 60% will not receive treatment either for their mental health issues. You're more likely to get treatment if you have a serious mental illness, having some pretty severe impairment of your functioning, but still about 33% or a third don't get any treatment for a serious and persistent mental illness. And then for co-occurring, that last one, co-occurring mental health issue and substance use disorder, and again, 92% don't receive treatment for both of those disorders. They might get treatment for one or the other, but not both. So I think especially because anxiety disorders and substance use disorders are so prevalent and so likely to co-occur, we really need to pay attention to how we're offering treatment that addresses both of those things. So the treatments that are out there, there are a lot for trauma that we talked about last time. There aren't as many specific treatments for anxiety. So I listed what there's evidence for out there, but it's not a lot of specific practices. So whereas if you have trauma, you're often looking for a specific kind of treatment, there's just sort of general guidelines for how to treat anxiety disorders. So first of all, medication trials, there's really good evidence that SSRIs, that's serotonin reuptake inhibitors, so drugs that keep more serotonin in your brain, selective serotonin reuptake inhibitors, I should say, SSRIs, which they were developed for depression. They're antidepressants mostly, but they also have a lot of ability to regulate brain states, including anxiety. So SSRIs are often used for anxiety as well as for depression. And those are things like Prozac, Zoloft, Celexa, Lexapro, Paxil, things that we often hear about as far as antidepressants. And I think that's important to mention that because often we think that benzodiazepines are the only real anxiety medications out there, and that's not true. SSRIs don't have the addiction potential that benzodiazepines have, and they have been found to be pretty effective for anxiety as well. So there are ways to treat anxiety without using benzodiazepines or something that has abuse potential. Behavioral therapy, of course, is really important for anxiety. CBT, or cognitive behavioral therapy, is the most commonly used type of therapy for anxiety. And that's really about identifying the thought patterns behind the anxiety. Because like we said, anxiety is really uncontrollable and excessive worry, often because we've generalized it in some way in our brain, or we've created a fear or threat response for something that's not really actually needs to produce fear or threat, might not be a threat. So really what CBT does is identifies what triggers the anxiety, then identifies what the thought pattern is that creates an anxiety response to whatever that is. So if you have a fear of dogs, a specific phobia around dogs, identifying that dogs are the trigger, and then identifying what in my mind makes me think that dogs are harmful or something I need to be afraid of. Maybe there was an incident in the past that made me scared of them, or maybe it's just I've been conditioned or been told or taught that dogs are scary, or that that's a fearful type of thing. And then identifying the coping strategies to deal with, if that's going to create this fear response in my brain, the way to cope with that is to reduce my anxiety, create some relaxation states, be able to change that belief in my mind and that thought pattern, to train my brain to not see that as a threat. So there's a kind of complex complex chart there that shows a little bit about how a CBT therapist is going to think about changing thought patterns, but really it's identifying what's the trigger, what's the response, and how do you cope with that response, and how do you change that pattern if it's become a maladaptive or a harmful pattern for you. And then the last one, which I think are really important for all of us to know about, are somatic skills that, remember, we talked last time, oh, you weren't all here, but in the PTSD talk, we talked a lot about that somatic experiencing or body sensations can be really a soothing treatment method. So a bottom-up way of reducing anxiety versus talking about your anxiety and thinking about your anxiety. It can be helpful to teach the body how to relax and respond to anxiety, and that changes the brain from the bottom up, sort of, instead of from the top down. So the ways you do that are by using relaxation strategies or mindfulness skills, and we'll talk a little bit more about that. But that's a way of sort of training the body to relax so that you can change that brain state from inside. So things, again, for us to be aware of with our substance use disorder clients, this is a slide from the PTSD talk, but I think these two particular things are really important for people with anxiety. First of all, that we need to create a safe space for them, a place where they feel like they can try a different way of responding to their anxiety than they used to. And if they feel like they're still in danger, that's not feeling like a safe place to do that. So as much as we can encourage kind of a feeling of safety and of calm, that's going to help them say, okay, this is a safe place for me to try something new, to talk to my therapist, to figure out what the trigger is for my anxiety, and to try to cope with it in a different way. It's a really hard thing to do when you're in a situation where you feel like you're in danger, to try something new. So as much as we can create and model calm and safety in our environments, the better someone's going to feel about trying a different strategy for anxiety. And then for all of us, these are some really key strategies in talking with somebody, even who's experiencing a lot of anxiety with their substance use. First of all, know some basic grounding techniques. You can always Google these, but some of my favorites grounding techniques are about taking yourself out of the fear of what's going to happen and grounding yourself in the present moment. So some of the most basic ways to do this are to say to someone who's in an anxious or even a panic attack state of mind, to say, describe what I'm wearing to you, so that they're focusing on something and talking about it in detail. Another one that we've used before is, tell me all the things that you can think of that start with the letter A, or that are the color red, and to try to take their brain out of the fear response and into some other activity. So it's sort of grounding them in the present moment and taking away that power of that fear. So while it seems silly in the moment, and often to say to someone who's having a panic attack, like, tell me what I'm wearing, it really helps the brain to focus on a task instead of focusing on the anxiety, which is just kind of self-fulfilling prophecy. If that's all you can think about, that's all you're going to think about. So it takes the focus somewhere else. Teaching clients some self-soothing or some soothing techniques, and often those are using the 5 senses, so things that they can touch that are soothing, listen to, smell, using essential oils, being in a quiet room, listening to music, having fidget things that people can play with when they're feeling anxious. Those are all going to, again, bring your body into a more relaxed state. And if you can teach clients that they can do some of those things on their own, then they'll have a different way of coping when they feel anxious. Often anxiety treatment is about slowing down what we think of as automatic responses. If I'm anxious about something, then I think, well, I just can't be in that situation because I'm just going to be anxious. But if you can help someone to slow down and think about, well, what happens first? What happens in your body, or what's your first thought? And how can we stop that from happening? Or how can we slow that down? It makes anxiety feel a little bit more manageable and more controllable if they see it as a process and not just an automatic thing that happens for them. Because there is a lot that goes into it. There's a trigger, there's a response, there's a thought, a feeling, and then some coping that happens, some sort of avoidance or something else. So just sort of slow that down and show them piece by piece what's happening inside their brain. Can sort of say there's lots of different ways to intervene here. You just have to know where those places are. And then mindfulness practices, the things that we teach our client about, focusing their attention on their breathing, either focusing on a visual or a reading or a devotion, something that's going to kind of bring their brain to focus on something on the present moment, is also going to counteract that anxiety. So I think if Fallon is ready, Fallon was going to talk a little bit about a client case that she had that involved some anxiety and substance use disorder. Are you ready, Fallon?
I'm ready.
Great, take it away.
So unfortunately, I did not realize that PTSD is no longer considered an anxiety disorder, and it's in the other category. So the client that I'm talking about actually has the diagnosis of PTSD and substance use disorder.
That's okay. I think we can talk about how the anxiety shows up in PTSD for sure.
Okay.
Great.
So this client opened with Mothers First in August of 2018. She's a 30-year-old female who identifies as Black and biracial. She has 2 children, age 8 months and 4 years old. I'm just going to go over her treatment history. I did do a little bit different with this case presentation. So this client is doing really well, does not have a lot of needs right now, but has come a long way. And I thought it would be good to share a story that is uplifting and kind of bring some hope, because when I meet with her, it's just like, that's so nice to have somebody doing so well. So I'm just going to go over her history a little bit, and then there is a few needs still. So she first began residential treatment in July of 2017, where she graduated WSA. She went to, I don't know exactly where the program was, but she's been sober since June 28, 2017. She then went to an outpatient with housing program in Minneapolis. She identified that that program was too triggering for her, and so she decided to switch to sober housing in St. Paul with outpatient treatments. A lot of times when I see clients do this, I don't necessarily support it, because I think sometimes they need to work through things. However, it worked out in this case for her. She graduated that outpatient treatment after 5 months, and the sober housing she was living in actually switched from sober housing to GRH housing, so she's been able to stay there since she moved in, so almost 2 years now. While she was at the sober house, she connected with somebody else in the sober house who was also working with Mothers First, and that's how she was referred into our program. The mental health diagnosis she has is PTSD and depression. In September of 2018, she delivered her son, who is now 8 months old, at a birth center. It was a very great experience for her. She's a pretty spiritual person, and you can really tell when you meet with her that that's the case. When we talk at our meetings, she still experiences triggers for her PTSD, specifically when she's in certain areas or reminded of certain people. She has a history of domestic violence with her ex, who's also the father of her children. But she is able to work through those situations when she experiences that anxiety. Just like you mentioned, she uses those breathing exercises, like breathe in for 4, hold for 4, and out for 4. She also does a relaxation technique where she focuses on like all different parts of her body and relaxing each one at a time. And those are ideas that she got from her therapist. She does also manage her symptom medication. She takes gabapentin, fluoxetine, and Seroquel. She attends therapy weekly, teaches yoga at one of the treatment centers, and she also practices yoga herself. So what's really awesome about her case is that she recently was accepted into the Jeremiah program and has become enrolled in classes for MCTC, where she wants to become an addictions counselor. So she's preparing for that by taking reading and writing classes now. She did have to complete her GED, which she completed in April of 2019. Since finding recovery, she's really improved her relationships with her family, specifically her mother, who she was pretty much estranged from prior to going into treatment. Some of the goals she identified is that she wants to continue pursuing her education for her and her family and have a safe and healthy family. So some of the barriers, she didn't identify any barriers, but through further talking with her, she identifies the ex-boyfriend, the father of the children. He is in prison right now, but she is concerned about his release. But she's already been working with her therapist about setting boundaries and how that's going to play out when he gets released. He doesn't have custody of the children, but he does still have some contact with the children through her. But she, I guess, feels comfortable with the amount that's happening, and she has, like I said, really been practicing those boundaries. And then the other thing about that is that his mother is also involved with the kids, but she said that she's been supportive in a way of, if he's not doing well, he's not allowed to. So she would send the kids, before he was in prison, she would sometimes send the kids over there And the mother understood that if he was like, he could not be there while the kids were there, and she honored that and respected that decision. So she seems also to be a support for her. So that's the case I chose to do today because, like I said, she's just come such a long way. Been sober for 2 years. Going to be is enrolled now in college and is really making a big turnaround from where she was in the past. And I think sometimes it's nice to hear a story like that, a case like that.
Yeah. Oh, that's great. That's so great. And yeah, I love that. I mean, so PTSD is her diagnosis, and that the anxiety for her, you said, was triggered by certain places, maybe around where she had been abused, or maybe if it was certain people, certainly the person who was abusive to her. And in PTSD, often what happens is it generalizes from just that person to anybody who looks like that person, or any males, or, things like that, that can make it dysfunctional. So to be scared of one person, if that person has hurt you, is certainly normal and probably doesn't impair your functioning in any way. But if you start to be scared of then everybody who looks like that person, or every place in that town, or kind of bigger, more generalized triggers, then you're going to be triggered more often, and you're going to be able to do less things or interact with fewer people. So that's where the anxiety can become a little bit overwhelming in PTSD, is when it's being triggered by a lot of different things, and it's not really specific to the abuse anymore. It's more like, oh, I can't leave my house because I'm not safe, or men are scary and I can't be around them, those kinds of things. So it sounds like some of that happened for her. And I love what you said about some of the that she was able to use to deal with it, the breathing techniques, and that grounding, that kind of being in touch with different parts of your body, which is both a mindfulness technique and a grounding technique, to talk about, to think through all the parts of your body and try to either relax them or kind of tighten and release, to kind of bring yourself back into your body and less into those fear thoughts. So would you say anything else, Fallon, about her anxiety, kind of where it was at the beginning, or how that interplayed with her substance use?
Well, I don't know too much because I wasn't her case manager when she first started with us. So I don't know when she started exactly where she was at. I just know that she's one of the clients that I actually see using techniques other than just managing with medication and just going to therapy, or at least talking about actually putting the coping skills to use.
Yeah, Yeah, that's wonderful. And I think that's a lot of what therapy becomes especially when you're talking about anxiety or PTSD. It's less about just talking through things with the therapist and more about, I need some skills for when I'm out there, because, that where the triggers are, or where I'm going to be having emotional reactions to things, I need actual practical skills that I can take with me and use in those situations. So that's really a great, I think, definition of therapy is bigger than just talk therapy. It's actual practice therapy. And things like that. So, want to open up for questions?
Yeah, let's do that. If you have questions, or maybe a case that you want to share, something in your experience working with folks, please jump in and unmute yourself and share with us, and we'll see if we either can come up with ideas or learn from what your experience has been. Okay.
I have a question. I'll jump in.
Sure.
When you were talking about how anxiety disorder can be masked or exacerbated by substance use, is there a recommended timeline for after somebody's diagnosed with substance use disorder and they've had some recovery time before they get diagnosed with anxiety disorder, to make sure that it's not an effect of SUD?
Yeah, that's a good question. So a lot of times, like I was saying, people might have been diagnosed with the anxiety disorder first. And so, but if they're coming in and we're not sure what's going on, if it's substance related or not, or kind of dependent on their substance use, and then there is sort of I don't know that it's in writing anywhere, but most mental health professionals will say we wouldn't give a firm diagnosis on something until someone had 60 to 90 days of sobriety, to see if those symptoms are really going to persist, or if it's really specifically related to that substance use, and longer if it's, been long-term habitual use versus someone who has just been using for a short period of time. So yeah, it's really hard to tangle out all the pieces. And in some ways, it doesn't hurt to be diagnosed with something like an anxiety disorder that might be related to substance use, because the treatment that you're going to get isn't going to be different, whether you're sober or, I don't think that there's anything wrong with using and learning some anxiety coping skills. That's not really going to impair your substance use recovery in any ways either. So I think unless we're talking about medications specifically for anxiety, that would be the case where you don't probably want to start someone on an anxiety medication until we're sure that it's an anxiety disorder and not a substance use disorder primarily. So those would be things that a psychiatrist or a medical doctor would probably tease out too, is what's important to medicate here. Is it the substance use or is it the anxiety? Yeah. And I think you didn't ask about this, but we hit on a little bit that often benzodiazepines are something that people that come to substance use disorder treatment have abused in the past, and maybe they started with a benzo as an anxiety medication, but that there is that abuse potential, that tolerance can build up, that you need more and more of a benzodiazepine to achieve the same effects, to reduce the anxiety, and that you can go into withdrawal, pretty dangerous withdrawal from benzodiazepines. So for us in substance use treatment, we often discourage people from taking benzodiazepines for their anxiety and try to focus on other ways of treating that, because there's abuse potential there. So an addiction potential. So I don't know if people have questions about that either, or examples of what you might do in your treatment settings around benzodiazepines or other anxiety treatments that you've heard about that have worked well.
Can you open up the screen so I can see all the people?
Okay, Alicia's gonna open up our screen.
Thank you. I have a question. You talked about developmental differences. Are there hormonal differences? Are women in different stages of their life more prone to or less prone to, and especially maybe women not necessarily in childbearing, but maybe menopausal women, are there differences?
Yeah, yep. I was just in a great webinar about those transitional times for women and the hormonal changes that happen that can both exacerbate anxiety and substance use, and a lot of those are pregnancy and menopause, especially, are times when our hormonal balance is out of whack and we're more susceptible to things like anxiety or substance use disorders as a coping strategy. So it's something to pay attention to for women. Women are twice as likely to experience anxiety disorders, probably not just because our brains are a little bit different from men, but also because there are different cultural expectations around being able to express anxiety and experiencing anxiety, and maybe not talking about it in males as much as we talk about it in females. So all of those are factors, I think. And there's been a pretty big rise in the last 10 years, I would say, in diagnosing postpartum anxiety, not just postpartum depression. And there's a new medication that's been approved by the FDA to treat postpartum depression that I wonder if it will be used for postpartum anxiety as well. It's called Aloe. I'm hoping to learn more about it.
It's
not a benzodiazepine, no.
And what would be a common name of a benzodiazepine?
Xanax.
Okay.
Is the one we see most
I don't
often.
know these things. So.
Yeah, and I mean, I think that's sort of an older model of treating anxiety. We don't hear as many, well, we do hear as many people using anxiety or Xanax for anxiety, but I think it was sort of that old model of just take something to calm down, and it doesn't matter if you're going to get addicted to it. It's sort of the same thinking that happened with opiates, happened around with Xanax in the 70s, 80s, 90s. So there are a lot of people who have been abusing them or have been overprescribed them, and maybe they're not treating long-term anxiety anymore. So yeah, I'm hopeful that we're going to usher out the era of benzodiazepines and usher in some new treatments. So it's exciting to hear that antidepressants have pretty good effects for anxiety. I think that's hopeful for a lot of women we treat who experience both depression and anxiety.
Are there any other questions? If you are having trouble possibly with your audio, you can always type in a question and Lucia will read it. We're nearing our end, so we'll take maybe one more. Okay.
Sherry's got one here in the room.
Yeah. So you mentioned medications such as the stimulants. Have you heard of anything where, so I'm thinking in terms of like an individual with ADHD who is prescribed a stimulant, but they also have anxiety. They're an anxiety prone individual. What kind of solutions for an individual such as that?
Yeah, so yep, she asked about people who are prescribed stimulants for ADHD, things like Adderall, that are stimulant medications that are also abusable and addictive in some ways. And so I do think that there's an anxious component of ADHD, for one thing. That part of that hyperactivity is anxiety. So you have to be pretty clear that that ADHD is what's going on, not anxiety, for a stimulant to be an effective medication. Because if you give a stimulant to someone who really has anxiety but has been diagnosed with ADHD, it's going to make it much worse. And so I think that that's where this idea about, or this, tendency to overdiagnose ADHD in children is pretty dangerous, because if we put them on a stimulant medication and what was really going on was actually anxiety, then we've just created a potential addiction situation where somebody's prescribed something that's addictive and abusable and not maybe treating what's at the core. So I think that that concern has led to is less medication for ADHD and more focus on behavioral therapies for ADHD. And so I hope that we're less sort of prone to medicating first, and more prone to observing the behavior and treating the behavior, rather than putting a medication in place right away, for kids especially, but I think for all of adults too. Yeah.
Wonderful. Well, we are at the end of our time. I have a few things I want to remind you. You will get an email from Lucia with your evaluation survey. At the very end of that survey is where you check the box to say, let us know whether you want continuing education confirmation. So make sure if I can't see you, make sure you've signed into the chat. Also, if you have colleagues who you would like to invite to join us, everyone is welcome. This is not a closed conversation. We want as many people to participate as possible. So please feel free, and you could do that by sharing the announcement that you get from Lucia, or you can provide their contact information to Lucia and she will send them an invitation. Finally, if you have a topic that you think needs to be looked at, let's have a conversation, find some information about, please send that information to us, or a speaker. If there's someone you've always wanted to talk to, let us be the legs to go and find that person, bring them in the room, and we can hear from them and also ask them questions. I want to let you know that we have launched a new ECHO group. It's for peer support workers in both substance use and mental health. And they meet most generally on the second and fourth Thursdays over lunch. So we've got a lot of them here. But it is closed and to just peer workers, right? So providers beyond that, we want to create a place where they can have conversations and discussions about their best practices and what they do in their work with people with substance use or mental health issues. Finally, we're not meeting in July. We take July off. Very few people come. So why not everybody take a vacation? So we'll be back with you again on August 1st and August 15th. You'll get your invitation with the topics included. And I hope that you all have a lovely July, and we'll see each other soon. Bye.
Thanks, everybody. And thanks, Fallon, for presenting.
Thank you, Fallon.
Yeah, great.
You're welcome.